we have care process models. Is there another name for it as you get into population health management? That kind of, right now it's brick and mortar clinic and hospital, but this now goes out to the population. Is there?
Well, I think you point out one of the core attributes is this is a set of technology that covers the range of the venues of care, including the home, and has to deal with a wide variety of heterogeneous systems. People have different electronic health records, you need claims data, you need data about the environment, for example. So the logic itself sometimes has the term care process models, sometimes it has the terms of evidence-based pathways. There's various vendors who provide content for targeted use such as detecting infections or medication management. And then a lot of providers will also create their own content. And one of the things that's interesting, Mark, for me as I learned the curve here, is that it's not only providers who are accountable for populations, but also employers are. State Medicaid departments are, agencies within the federal government, and obviously as you go overseas, various countries and various national health services are concerned with populations too, all of which use this array of content with different names that come with them.
So care pathways was the term I was looking for that I couldn't think of. And we're pretty excited about the potential of, again, we've used care process models to do the evidence-based care within our system, and see care pathways as extending that out to the employer, extending it to the individual, the patient, or the member, whomever. It's pretty exciting what you're going to do.
I think it's a result of remarkable changes in healthcare that you live. I used to live, but we try to support of managing people over time, managing their health as distinct from when they're sick, covering the continuum, and things along those lines. And I think one of the things we'll see, Mark, in the years ahead is right now a lot of these care models, or whatever the term is, tend to treat a population as being homogenous. All diabetics are the same, or all people with clinical depression are the same, but they're not. They can vary in terms of ability to follow the path, they can vary in terms of education levels, they can vary in terms of genetic risk factors, et cetera. So I think working with Intermountain and some of our other client base will see more micro-targeting of populations that intended to get more effective, tailored approaches to individuals.
Yeah, and I got to tell you, at Intermountain, we're pretty excited. Having lived this kind of insular world of self-developed, which you lived actually at Partners for a long time, now to have the wisdom and the skills of lots of other organizations, as you mentioned, that you're working with, that can really help us bring this population health together. So it's pretty exciting.
It is exciting, Mark, and I think one of the things I know you've learned, I have too, is that if we're going to solve the issues that plague healthcare, it will be because the community comes together, the providers come together, we come together with the health plans, government, advocacy groups, et cetera. And clearly there's competitive instincts that ripple throughout that, but nonetheless, there is a higher objective here, which is one of the reasons people come to this event, is to share and learn from each other.
Yeah.